hand over to
all right, so what we're going to do in this part of the presentation is that we're just going to give you a case study of a hospital that in many ways got it right, to show you that there can actually be solutions to some of these seemingly insurmountable problems. The one that we chose is Intermountain Healthcare, which is comprised of 22 hospitals, over 150 facilities that are located across most of Utah and part of southern Idaho. So it's the main player in healthcare in Utah. They have been a long-time leader dating back to the 1960s in the use of information technology in the clinical setting. They made at least 2 major attempts to bring quality control from the physician level, and it's not met the success they wanted in the 80s and 90s, and so they wanted to find a new approach. What they realized is this quote right down here. The lesson that they took is that they weren't engaging physicians with what they do every day, which is dealing with patients. They were trying to turn them into managers. So maybe we can get into more of that when we get into the discussion period, if you wish. The approach, the strategic plan they used to bring about this clinical change was to focus on four families of care. The actual clinical conditions where the physicians meet the patients, clinical support, service quality, and administrative. What they found is that out of 600 work processes in the clinical realm, 62 of them accounted for 93% of the business. So does it make sense to focus on that 10% and get that really good at that 10% and reap the rewards of doing that? Similarly,
are you saying they should focus on the 10% or focus on the other 90%?
Focus on the 93%. Focus on those 62 things that comprise 93%, so that you can do those things really well. You're going to reap more rewards out of doing that as well. Similarly, they found 30 processes, 15 chronic, 15 acute. That's 85% of their outpatient clinical volume. So that tells you where to focus your efforts, and that's where they did. They also looked at the support services, which, as you can see, include everything from pharmacy to nursing units and procedure rooms. What they discovered is that 5 out of the 40 procedures that they performed in respiratory therapy accounted for 90% of the work. This tells you where to put your time. The ultimate goal, as you see, is listed right down there. The key to this, and what you're seeing a lot in the literature, is in the argument about evidence-based medicine. So it's moving away from justifying evidence-based medicine in and of itself and looking at how do you go about implementing it in the most effective way. The approach that Intermountain took is by engaging physicians at every single level. They started with the Guidance Council, which took the responsibility for seeing all these protocols and guidelines being developed throughout the entire system and seeing them through. What they did is that they employed a physician, paid 25% of that physician's time to lead this council, rather than asking them to donate their time, lose billable hours, and put into it. That physician was given a full-time nurse to work with them, and what their job was, they were sort of the managers that oversaw these development teams that you saw down here. The development teams were made up of multiple physicians, a full-time physician and a full-time nurse that would go and actually go through the literature, develop protocols, have physicians in their teams that would go and implement this on the front lines, gather data, and pull it back in. The Guidance Councils had a parallel structure with hospital management, which you see down there in number 3. The hospital administration basically had senior vice presidents, the operational staff, the folks who keep the lights on and keep things running, do the financial work, to make sure that in this clinical improvement effort, all of the resources were aligned to facilitate this improvement. Yes, sir.
This is one of the worst slides I've ever seen in my life. So you might want to just highlight it before you move on. What are the 3 things people are supposed to take away from it?
The 3 things, you know what, I'll tell you the one thing that's most important. Physicians were engaged at every step of the process. When you see what physicians were responsible for, provide their expertise, make sure that protocols stay current, make sure they kept their colleagues aware of state-of-the-art care, and to operate a specialty clinic for the patients that did not fit the protocol so that the hospital could learn from the exceptions and build that in.
So it's not the hospital ramming it down the doctor's throat.
It's grassroots. It's bottom up. Yeah.
Okay.
It's bottom
just
up.
want to make sure.
The other revolutionary thing is the fact that every one of these development teams had an IT support staff assigned to them, which included statisticians, which included programmers that would that would make sure the implementation of these processes, of the computer position reporting, that everything that was done at the bedside was actually integrated into the system. Meaning that this wasn't a group that studied, came up with this great protocol, but then went to someone to implement it. It was actually being implemented on the fly.
16 minutes gone by.
The result is they developed a patient care management system, which looked at where outside of the direct clinical setting did the hospital staff engage with patients. It was a merger of their clinical and administrative data systems. It allowed you to capture the data once. If a medication was administered, if someone was in a procedure room, if a test was given, that was inputted, and so you didn't have to recode. The rationale behind that is that 15% of the biggest expense of the hospital was the operational staff. 15% of what the operational staff did, all their time was spent just coding data into billing computers. So you capture it once, you capture it right away, you realize huge benefits. They merged the electronic medical record into the patient care management system so that this is something physicians interacted with as well. It was one system, physicians, nurses, pharmacists, everyone engaged with it. And there were several built-in features to encourage the adoption, including an antibiotic assistant, which took you through the basic decision report that we talked earlier about how you can look out for complicated interactions, and also ventilator settings. The key factor in influence physician buy-in is action number 2 down here. At any point in the system, a physician could override the protocol if it didn't fit the need for their patient. They were asked to provide a reason. That reason was not to determine who's breaking the rules, but to learn from like where are the deviations, where can we improve the protocol. And also, as you can see in the first slide, there were direct financial incentives. Most importantly, doctors spent less time going back and transcribing the notes from a meeting they already had. When they were in meeting with their patient, they were entering their data right there. And so you can see an over 90% return on investment per patient. The keys to Intermountain's success is they took a holistic approach, they engaged the physicians, respected their autonomy, they had an overall focus on implementation all the way through the process. They developed guidelines and protocols from the local patient population. They took the data, they tested it, they took the results from the patients that were coming in through their door, and then they worked that in to improve the protocol. And finally, what I'll point out is that I read a book about a study in 2004 that only 3 of these 65 protocols they developed were actually achieved consensus by 2004. My caveat to that is that I don't think it's unreasonable. It takes a long time to move towards adoption, but still, don't think the conflicts don't exist at Intermountain, but they've got a good system for restoring it.
You've reached the 20-minute mark.
All right, let's get this slide and go right to ROI.
You be quiet.
Okay, so real quick, basically lots of money saved, which is you would think would be a good thing. As you can see, just a couple of quick stats here. The percent of patients admitted before the protocol versus after the protocol, or I should say within the protocol, obviously patients admitted has gone down, which shows that there's better medicine being practiced. It's quicker, it's more efficient. Unfortunately, a secondary effect of this was that the hospital ended up going into the negative $500,000. So, yeah. So unfortunately you can see the conflict here from a business point of view. This might not be, you would think at first glance, the best protocol to implement, but what happened when they brought it to the board is the board said, you know what, this is clearly the best option for the patients, it's working within the hospital, we need to keep moving forward with this. So, next slide. So this is just more of the exact same, showing on the left-hand column, before the protocol, numbers were really bad. After the protocol, great improvement. National rate, we're way above the national rate. So beta blockers, the first line on the first chart, basically just showing that doubled what the national rate was. Way more efficient. It's really great.
This is just giving the right medication at discharge for someone who's coming for a cardiac condition. That's all.
Thank you, because this is the worst slide I've ever seen.
Great. Hey, sorry. Still entangled. Okay, so another sort of case study, we're looking at pneumonia here. Basically during the protocol development, it was determined that 3/4 of the patients diagnosed with this could be treated as outpatients. You don't need to have them stay in the hospital overnight. And then also the antibiotic recommendations, just prescribing the right medications, 10 to 12 medicines that were not necessarily necessary.